I'm Joel Cohen, and welcome to another episode of Scientifically Speaking. And I'm excited to be talking to some experts about hair disorders today. We have Dr. Cheryl Burgess, we have Dr. Reena Jogi, and we have Dr. Marc Avram. So I just want to have everybody just take a few minutes and introduce themselves and really talk about something that's been a signature for this series as far as their hat. I'm wearing my Colorado Avalanche hat. The Avalanche just started letting people back into the arena last week with really limited capacity, about 3,000 of the 20,000. And I went on 2 nights. I brought my son and 2 of his friends in his cohort on a Wednesday night. And then my 8-year-old daughter was jealous, and I went on a Friday night and she ate all the concessions possible. So this brings me joy, just back seeing live hockey safely and thinking about literally my 8-year-old daughter eating her way through the stadium. So Dr. Jogi, can you jump in, tell us about your hat, your practice, and what you do, and about hair disorders, your passion?
Absolutely. I'm Reena Jogi. I'm in Houston, Texas. I've been in practice only in Houston. I've trained primarily here. And I stumbled into hair loss a little bit serendipitously. It's just something that grew very unexpectedly in my practice. And now it's at least half of what I do. And I still enjoy general dermatology, but hair loss has become a very big passion of mine. I primarily do a lot of platelet-rich plasma therapy, and that's how my hair practice has grown. And the hat I'm wearing is from the US Open. It's from a long time ago. I'm not a huge hat person, but I scrounged this one up. It's one of the few I own. But tennis is my favorite sport, and the US Open is probably the single greatest sporting event I've ever been to. And I think just with COVID, New York is near and dear to my heart. New York was the last place I went to in February before the world shut down, and I can't wait to get back there again. So maybe next year will be a great time to go again.
And then Dr. Marc Avram from New York, who really lectures on hair disorders regularly, has written about it, and does a lot of hair transplants as well. So your perspective, Marc.
Yeah, so I'm a dermatologist as well, and I got interested when I was a resident. I did a year of research in the lab, and I was working in keratinocyte biology, but the professor I was under was a hair expert. So I used to go to the clinic with him, and frankly, back in the 90s, we didn't have follicular unit surgery. They were still doing plugs. We didn't have PRP. We didn't have lasers. We didn't have finasteride. We just began to have minoxidil. I saw how upsetting this is to people, so I decided to pursue it. Luckily for me, the follicular unit hair transplant surgery came just when I was done with my residency and did a fellowship in it. And I spend the majority of my practice doing surgery, but also medical hair too. Seeing a lot of medical hair too. So I do both the medical and the surgical, and enjoy it a lot. And definitely, I'm wearing a Yankee cap. Always been a Yankee fan, like the Mets too. Like you can like both teams. I'd say this year people are more excited about the Mets because there's new ownership in New York, and they're hoping maybe the Mets can turn it around. But hey, it would be so great for Yankee Stadium to be full later this year, and to have people back out. And as Reena was saying about the US Open, I would love to have the US Open have people in the stands again, because to have the energy of New York back is something I really look forward to, because the energy's been missing, but I feel it's starting to come back, and I look forward to it.
And I hope to get to New York and hit the US Open with you and maybe see you do some hair transplants. So Cheryl Burgess, we've been friends a long time. I know you have a very significant practice in DC that focuses on all kinds of dermatology, but you see a lot of hair loss disorders. So tell us about your hat, your team, your practice.
Yes, I am a certified dermatologist in downtown Washington, D.C., and I first got involved in hair transplants when I was a resident. In fact, it was the 4-millimeter punches that we used to do. And so eventually it evolved to the follicular units. And so I was doing hair transplants in males and females, and then found that I seem to be more interested in the medical aspect of hair loss. So pertaining to mainly women, although I do see some men regarding hair loss, but a lot of the non-scarring and scarring alopecias. And I also do some clinical research in alopecia areata and all that. So I have a long history with hair, and I still love it. It's the kind of practice that, you know, you don't want to see a hair loss patient at 4 o'clock on a Friday. But I think that's why a lot of dermatologists don't do hair. And it's unusual that most people who are very trained in hair don't do it. So that's why I love it. And so my hat is a Gonzaga Bulldog. And that's my bulldog you hear in the background. He's squeaking a toy, but for the most part, how I got interested in doing or getting this hat was because my father played college ball, NCAA ball, and he was a All-American for his 3rd and 4th years playing. He actually was the highest scorer in the nation. He was drafted to the NBA. He was 27th in the draft, 3rd round. And so I grew up in the basketball in the court bleachers. So I've been a Gonzaga fan since I was little, and my dog is a Gonzaga Bulldog. And so that's why I have this hat.
That's awesome. I did not know that.
That's amazing.
So all of us are board certified dermatologists. All of us see patients that have hair loss disorders, and we offer different treatment modalities in our practices that we'll talk about. So let's start it to really something that's really the most common thing we probably see or hear about or get calls from friends is male androgenetic alopecia. And Marc, I'm going to have you take that. So when you're assessing a patient, you're looking at them, you're talking to them about the diagnosis, what runs through your mind and how do you make that diagnosis?
Well, first I get the history. It's like, just my advice is approach a hair loss patient the same as you would any patient in medicine, not just dermatology. Get the history, how long it's been going on for. Ask them what medications they've done, what has worked, what's not worked. Getting a sense of, someone comes in and says, my hair's thin gradually over 20 years is one trajectory than someone who says, I had a full head of hair 3 years ago and lost 80% of their hair. And getting a sense of what's worked and what not worked, and to ask the person, what about this bothers you? Because each person, what bothers them and their concern can be very different. Somebody may come in and say, if you can just stop my hair loss where it is, I'll be happy. I just don't want to go further. And other people are like, they really want to restore their hair. So the first thing is to examine the scalp, make sure it is male pattern. Very common, I think, mistake a lot of residents at the beginning. They just assume if someone's losing the hair, it must be genetic. Examine the scalp. And just like the rest of the skin, if there's any doubt, do a scalp biopsy. If there's any doubt you think there may be a subtle scarring alopecia, do a biopsy. If you think clinically you're comfortable it's male pattern hair loss, then talk to them about based on the history and what they've done and their expectations, both medical and surgical. So I talk about everything with people. The majority of people end up doing medical, but for some people, surgical is the right answer. So that's how I approach it.
Now, do you start each appointment, do you take photographs? Do you take it in the room? Do you have a photo room? And then do you actually use the specific scale and score them on the degree of androgenetic alopecia?
Yeah, I think photos are, I always tell patients, I think photos are helpful because whether you do medical therapy or surgical therapy, the correction happens so gradually over so many months. Sometimes you kind of forget what you look like. And it's not that uncommon for somebody to come in and say, I'm not really sure. I'm not sure if I'm better, if I'm worse. And then you look at then you look at the photos and you see the difference, right? So I think photos are important to do when they come in. We do it I'm in New York City. I wish I had a dedicated photo room with lighting. I think that's an important thing. I don't, but we have a background and we do standard photography. And I think it is an important thing to do. On the other hand, I will say too, also from surgery, that if the lighting isn't perfect, you can make a medical or surgical result look better or worse than what it really is, depending on the lighting. If you just take the angle slightly different, the slightly lighting, which is why it's really important to try to do a standardized photography. each person. So I look at a macro, not a micro assessment. If you look at someone and you you just clearly see there's more hair in the frontal scalp, that means the PRP may have worked or the surgery worked or both. And so I think photography is a good thing, mostly because it happens so slowly. People honestly don't remember what they look like a year or two earlier.
So we have plenty of room in Colorado. You don't have to go to the dispensaries for anything. You can just hang out at my office. We got photo rooms. So maybe you should retire in New York and join me, because we definitely need
hiking in the summer and skiing in the winter. Yeah.
That'd be great. We play tennis. So Reena, we see so much male pattern baldness and androgenetic alopecia that I think really, in my perception, that overshadows the women that really suffer from this condition as well. And I know you see a lot of these patients. Can you take us through the sort of same questions I asked Marc in terms of you're evaluating these patients, what you talk to them about, what you're looking for, how you explain it, photo documentation, use of scales, that type of question?
I really take a very similar approach. History, I think, is very important. One of my most important questions that I ask is about family history, because I think that does kind of project the trajectory that that patient will take. If the male can see his father or his uncle or his 17 brothers have all lost hair at a certain age, and if he's seeing himself on that same path, that might change the interventions that that patient wants to take. So I think that that is very important. We take pictures. We don't take pictures for all of our medical hair loss visits. We take pictures religiously at our PRP visits and at the bulk of our medical hair loss visits, but I do have a very busy general dermatology practice as well. And so we're not always able to do it. I do find in today's age, digital age, it's oftentimes the patients have taken a lot of pictures themselves. Patients have their little dedicated album on their smartphone that is hidden, and it's just their hair. And I think that's a good reflection of how, I don't want to say obsessed, but how much that this can consume a person's life. I think that hair, it defines a lot of us, and it defines a lot of patients. And so there are a lot of dermatologists who don't treat hair loss and who get so frustrated when they see hair loss patients, because it seems like patients don't have perspective. But since it is the first thing that people see, it really can be consuming. So when I notice that they have their own little album and they show me pictures on their own, I do know that this is a person who is really going to want to be a little bit more aggressive. In my practice, I don't do surgical hair loss treatments. I don't do hair transplants. I refer out for those, but that might be a situation in which I might say, okay, well, this is the best treatment approach for you. And it might be better that we start a little medical therapy, but you start looking and getting an evaluation for a consult. And I do think pictures are extremely important. I do think pictures can lie as well. But a lot of times these things are, so you have to try to standardize them as much as possible. But a lot of times sadly, they're a little bit subjective as well. How does it make a patient feel? Does the patient feel like their hair is better? Do you walk in the room and they look better to you? Those type of things are very hard to quantify sometimes. I did purchase a very fancy scope to count follicles, but we haven't been able to use that successfully yet in our practice. We're working on it, but it's been very cumbersome so far.
So for men, we're accustomed to the sort of bitemporal recession and that overall receding hairline. And if you think about scales and things that we can look at, can you just describe, what you're looking for when you give a woman a diagnosis of androgenetic alopecia?
So for women, they're often going to come pretty early, because women, they really notice that thinning very, very early, because they start noticing the widening of the part. That's the very first sign that they come in complaining about. And then a lot of women will complain about thinning in the temporal areas. And I find that I don't see too many women, or at least in my practice, it might be a skewed representation. I don't see patients who come in too far advanced on the scale, but I do think it's important to discuss that with them, because if they are very advanced, then their chance of improvement with medical therapy is going to be a lot less likely. And so they're going to have to be referred out for surgical therapy. So I do find that widening of the part, and noticing that they can just see more scalp in pictures. I think just because we're in the selfie generation, a lot of my patients will notice that, oh, wow, I feel like my scalp reflects in pictures and that's all I can see. is my part. And so that brings people in fairly early. I do like to address that with them. And, it's a little bit of a different pattern because they do have thinning that's a little bit more diffuse on the top of the head, whereas men have the recession of the hairline and the thinning at the crown. Women, it tends to be a little bit more diffuse, but it catches their eye early just because, we spend a lot of time on our hair for the most part.
So this next question is for Cheryl, and Cheryl, you're going to get a chuckle out of this because I saved this question for you, but many, many years ago, and I'm sure you're going to remember this, you gave me some advice and you said, hey, Joel, sometimes the media reaches out to you and you have an opportunity to do a segment on something and you're thinking, do I really want to do a segment on this? And you gave the example of a bed bug segment, and then you were stuck with it and you were like the expert on bed bugs forever and ever. And my next question is really about telogen effluvium. And it's really one of those things that I think of in that same category, or as you mentioned, the 4 o'clock patient on the Friday afternoon. It's something that's so common. It's something that's very challenging because you explain to patients that this may be involved with a stress from a few months ago or a surgery from a few months ago, or as we've seen now, even COVID, the amount and the diagnosis of telogen effluvium has exponentially increased. So can you talk to us a little bit about telogen effluvium?
Certainly, Joel. And, I'm glad you brought up that topic because I've seen a lot of COVID hair loss, particularly positive hair pull tests. And that's what I do when patients come in. I'm looking, first of all, I'm trying to determine, is it hair breakage or you're actually losing hair? Because people confuse the two. I'm going to also examine, the hair that they bring in the bag with them. And, for the most part, you can kind of eyeball the amount of hair that they bring in the baggie if it's one day. Is it more than, 100 strands or 80 strands? And I think that, when we see an overabundance of hair shedding, then we want to take a good history in that. I try to nail down, how long ago did this start? Was it, the holidays or whatever? A lot of people, they're so, distraught that they can't even remember when it started. But if you pin them down, usually they can. And back in June, July timeframe, a lot of people, it was due to everything shutting down with COVID, just all the stress and the kids not being able to go to school and couldn't see the parents and all this. It created a lot of stress and strain on a lot of people. So come June, July, I was seeing probably 5 a week when we could open our practices again. And I think the main thing you have to stress to a lot of people, and I've saw it a lot in men, which is unusual because I see it more in women, but to stress that this isn't a permanent hair loss situation. I know the amount of hair that's lost, people think I'm going to go bald if you don't do something, for in the next month. And I try to tell people, well, let's work you up to determine what it is, because I don't like to always blame it on stress. It could be something medical that is going on, or they just had a surgery, or we saw less elective procedures during COVID time, but it could have been, a car accident. I had one woman who was just in a car accident and it occurred. So if you give the patient assurance and confidence that this is going to play itself out, it's just mainly a red flag that something happened or your homeostasis got off, and that we're here to just kind of monitor it. But the time you come to me, it's halfway over. I mean, it doesn't really last that long. And that is the main thing I try to convey to the patient, is that this is not a permanent hair loss situation. Convincing the patient of that when you don't give them anything, when they leave the office, is distressing. So I try to give them something that it's not going to hurt them. It may help them. I usually do the oral supplements and things of that nature. But one thing I do when I take photos of patients, I do a midline part on everyone. And we part the hair so that we take a vision of the top and the front, so we can see the temporal areas, both lateral sides and posterior. And I keep those photos so when they come back in the office, I can compare them. Also in telogen effluvium, when the hair growth is returning, where it seems like, you know, they're out of the woods, what I see a lot are little squirrely kind of baby hairs. And so if you point those hairs out to them, then they see, oh, my hair is growing. So there's a lot of things that physicians can say, whether they treat hair loss or not. And telogen effluvium is one of the more common things that come in, particularly women who had babies. I can guess the baby's 3 months old. And that usually happens that, oh yeah, here's some new hairs, this is coming in, this area is coming in, and they're usually fine with it. But if you don't take the time to explain it to patients, that's when they have issues. Or because usually the telogen effluvium patients who come to me have seen 3 other dermatologists before they got to my office.
So Mark, you mentioned that, you know, sometimes you'll take a biopsy. I'm really impressed with my ability now to actually use my dermatoscope sometimes, do a hair pull test and look for telogen effluvium and look for really the, you know, the overall area of the follicular structure that you pull and really examining that. So can you talk to us a little bit about some of the methodologies that you might use in terms of diagnosis for hair disorders, and then really talk a little bit about alopecia areata, because that's one of the things that, you know, early on we tend to need to really look out for.
Well, first, diagnostic, I think history examination. You know, you can do dermoscopy. You know, Antonella Tosta in Miami has a beautiful textbook reviewing the follicular dermoscopic features that you can look at. And you can point out lichen planopilaris and the different disorders that way. I think it's amazing, but still, I usually end up biopsying somebody, right? I think the scar is so small. People are always concerned, how much hair am I going to lose from this biopsy? I'm going to lose even more. I'm already losing hair. And I assure them that it's literally like a little glass out of a pool. You're not even going to see a difference, you know. And I think the biopsy is very useful. And I'll tell you, and I think everyone on this panel will say the same things. You know, when it's easy and across the room, it's easy, but sometimes we get surprised. You know, you thought somebody had a little sebderm and it's lichen planopilaris, and you're like, well, thank God I didn't transplant that right then. And then you might transplant someone and they like, you're looking, oh, was that a little like 2 years later? So I believe that there's a spectrum of all of these disorders, just like there's mild acne and severe acne. And I think there's scarring alopecias that can be very mild and can be mixed in with male female pattern hair loss. So the point is, be humble and biopsy easily is what I would say to get a diagnosis, because I don't think any eye or any experience is 100% correct in this. Regarding alopecia areata, I think that's, again, you know, one of the things with that is you see it in children, young children, teenagers, adults, all age groups. It's devastating. I think most people, as you know, have the limited type of alopecia areata, generally treatable. Most people we treat with topical steroids, IL Kenalog, and they do very well. But then there's a ladder that you go up if they don't respond. Some of the other treatments that I think have had some good results, more extensive alopecia areata. The problem with them is they now are reported to have an increased risk of cardiovascular events and cancer. You know, so you have to weigh that with it. I will say PRP has also been reported to be a good treatment for alopecia areata. So to me, my first line in treating alopecia areata is topical steroids and intralesional. And then I go up the ladder if they fail after several rounds, then we try other things. You do not transplant alopecia areata.
Do you do any contact sensitization therapy?
You know, the problem with that is patients usually don't like it. I sometimes use tar. I like dithro cream, and and I tell them to leave it on and build up to it. Not a lot of contact, because if they get an exuberant reaction, people kind of get disappointed, and often we can treat it alternatively.
So Reena, in residency, we all saw various types of alopecias, and we probably all had the opportunity to really look at scalps and diagnose fungal processes, and in some cases, other infection processes, such as even syphilis. So when you're thinking about these things in your mind and you're assessing the patient, can you walk us through some of your thought process?
So I think, again, the history and examination are so important because they really do guide you. You're going to see subtle findings. I, too, use dermoscopy quite a bit when I'm looking at the hair. I think that definitely I can see a lot of things, but I also think that patients feel better when you actually take the time to look at their scalp, because you might be the first person who's actually touched their hair and touched their scalp and looked at them and gotten very close to them. And there's something a little therapeutic just in doing that little bit. But when you're looking, you look for the subtle changes. I think the two things that trick me the most are a very, very early lichen planopilaris or an alopecia areata incognito. So I try to look for subtle findings there, a little parafollicular erythema or scale. I try to see if there's subtle findings of alopecia areata. I think syphilis is not something I see a ton in my patient population, although it is making a comeback, and probably after a year of being cooped up, we might even see more of that these days. It's hard to know. But if you see that, if you just see a weird pattern, something that doesn't fit into a box, and if there's that small inkling of doubt, I think a biopsy is fairly easy. It's fairly low risk. Patients don't love them, but they do like having an answer. And sometimes I do feel like the patient has not seen his or her last dermatologist until they've had a biopsy, potentially. Unless they're improving, of course, but if they're not improving, the buck needs to stop with a biopsy. And so that's my approach as well. I like to sift through it, take a history, and see if there's any red flags that kind of make the pattern seem a little atypical. And in that case, I'll do a little bit more digging, maybe check some blood work. I don't check an RPR in everybody. I do if it's clinically appropriate, but I do like to keep it in the back of our mind.
So there's certain things that obviously we don't need a biopsy, things that are common that we probably all see, things like traction alopecia. Cheryl, can you talk to us about your experience advising patients with traction alopecia? How do you talk to them as far as the do's and don'ts with that condition and really their chance of regrowth?
Yes, traction alopecia, we used to think that it only occurred in, little Black girls, but that's not the case now. If you look at a lot of the celebrities, they have tracts and, they go from a short hairstyle to a long hairstyle. And we see that pretty much across the board, everyone wants different hair and long hair and this photo shoot or what have you. And so I'm seeing it in my office across the board. So it's the event of tight pulling and constant pulling against the hair follicle that eventually start to cause inflammation and then damage to the hair follicle, and eventually, in some cases, permanent hair loss. So it's important that one, particularly my Black patients and the children, is that if I see them come in with adult, I may make a comment, even though the kids aren't my patient, the adult is my patient, in that, braiding the hair, particularly in children, so that they don't have to do it on a daily basis. And I think over the last year, I've seen less of it because kids haven't had to go to school and be tidy and neat when they left for school. And so I don't think I've seen a lot in 2020, but generally I do, because the braiding is so tight to keep the hairstyle for a week. And basically that's why mothers will do it. Then you have adults who have locks. When the locks get too long and heavy, that can also cause traction and tension on the hair follicle. And then, like I said, a lot of women are putting tracts in their hair for the different long hairstyles and things like that. And we see that. There are bonding glues that stick to the hair that are very difficult. You have to have a solvent to get them out. And so there are a lot of different things that really contribute to traction. And so I'm seeing a lot of it. All you can do is advise people. It's a beauty aspect. And when someone wants to put tracks in their hair, some of them have clips, some of them are better than others. But just to educate the patients that this can also cause a permanent hair loss situation.
So, from a traction standpoint, a lot of times you look at it, you make the diagnosis and you counsel them, but there's other conditions where, you may waver and look really closely at the scalp. And can you talk to us a little bit about things like centrifugal scarring alopecia, and also discoid lupus is a big one to talk about as well?
Yeah, I get a lot of CCCA, and that's centrifugal cicatricial alopecia, and also abundance of follicular frontal fibrosing alopecia, which is I'm seeing also in white patients, pretty much all across the board. My practice is downtown DC. I live and practice around a lot of embassies, so I see people from all over the world, and practically I've seen it in every ethnicity group. You can say lichen planopilaris or LPP is maybe a variant of CCCA. I think they all kind of overlap a little bit. And so when I see my patients in the office, usually they've seen several other dermatologists. And particularly if they're Black patients, they'll say, no one ever looked at my scalp. No one ever, touched my hair. It's unfortunate. And so, of course, that's the first thing I'm going to do. I'm going to part the hair. I'm going to look at it. I have my dermatologist. And I look at the changes that you typically see with CCCA. And if you treat the inflammation, and my main treatment that I use is I start them on rifampicin 300 milligrams, in addition at the same time as a Keflex 500 milligrams twice a day. And they take them, and I feel that the synergy of the two medications really help. I put them on that for 2 weeks, and then I see them in a month, because I really want to see, has the inflammation gone down? Now, most patients will give you a history of, I had itching, I had soreness, I had head tenderness. It usually is a sign or symptom that they can say, and they can almost state when it started. And the continuation of these symptoms tends to cause the telogen effluvium, or the shedding of the hair. And so patients are really frustrated. Not only are they losing hair, their scalp is sensitive, it hurts. And so when the patients come back to my office in a month's time, like I said, I keep them on it for 2 weeks. And I have them compare on a scale from 1 to 10. How is the sensitivity? How is the itching now? And probably 90% of my patients, it's gone. And that's when I know I'm doing something. Then I start from there. Now, this is what a normal scalp should feel like. And my LPP patients, I do the same thing. As long as their symptoms, the situation or the condition is active. So that's what we want to do. We want to slow that down. I usually will use a topical steroid as well. But usually when they come back in a month, they've gotten hair growth in that area. And so that's why I take photos when they come in, so I can do a before and after. And actually on my Instagram, I have quite a few cases of, 1 month, I'm 4 weeks, 5 weeks, 6 weeks after they were treated, and you definitely see an increase in density. So that has been my regimen for 33 years. I learned it from Dr. John Kinney, who was my chairman when I was going through, one of the attendings when I was going through dermatology at Howard, and that's how he treated it. And I have treated it that way ever since. I rarely do intralesional steroid injections because I think it leaves a lot of atrophy on the scalp. and particularly in African Americans that lose a lot of hypopigmentary changes. But that regimen tends to work for me every single time. So that's what I do for that in LPP.